Professor Greg Snell should be well known to a lot of you here as well. Greg is the medical head of the lung transplant service here at the Alfred and has been in this role for about 30 plus years now. And he is also well renowned in Australia and internationally for his research in all things to do with lung transplant, and particularly improving the organ donation rates for lung transplant recipients and getting more patients transplanted.
So I'll be continuing the discussion about rejection and how we will diagnose it and how we prevent it. So why do we get rejection? Lucy's touched on this. Our bodies try and reject anything foreign, and this is a clever evolution that helps us to clear bacteria, parasites, and indeed cancer cells. And of course, it's foreign, so a transplanted lung is recognised as trouble, and the body thinks it's a parasite and tries to move it on. Without suppression of our immune system, using our transplant medicines, our bodies will attempt to destroy the transplant. But there's this balance. If we give too much, we risk infection and cancer, and if we give too little, we risk rejection. And as anyone connected with lung transplant knows, there's a juggle, and we're constantly looking at markers that try and tell us which side of the line we're at. Our strategies generally over time with the transplant, how much immunosuppression we give, the graph rises to a peak there in the first week or so with strong things initially through the drip and then subsequently tablets. And then there's a sort of a master plan of slowly bringing it down over time. If you get rejection, you give more immunosuppression, and if you get problems with the immune system, we back off a little. And the holy grail in lung transplant is to try and work out where does this line sit in an individual person. Because for some people we need more, and for some people we need less. And we won't be talking about it today in any detail, but that's certainly one of the interests, and indeed some of the other work that Steve's done as well, trying to tell us what are the predictors of where that line should be. And the other thing the graph doesn't talk about is what happens out here at 10 and 20 years. Should we be going down to zero? The question that everyone asks who's had a transplant, can I ever stop these drugs? And the answer is probably no. It needs to be in balance. And again, we will find some people who can run with less and some people with more as we get cleverer. What is rejection? It's a phenomenon that does acute rejection, can come on over days or weeks, and it can make you breathless, tired. It can push down the lung function, which we worry about it chronically staying down, but it can come down in the short term, can drop your oxygen, the X-ray changes. It shouldn't have all this white fluffy stuff in there. And you can see something if you look in the tissue. A bronchoscopy is used to look at the tissue, and there's Glenn all suited up doing the bronchoscopy there, up in the clinic by himself with no anaesthetic. But no, and you pass a tube down into the airways and into the lungs, obviously under very careful conditions with an anaesthetist and everything being safe. The standard way of doing a bronchoscopy is to pass down into the airways and out through the airways into the sponge of the lung, the pink there, and grab the little forceps, pull back and send that off to the lab. And it's relatively complex in that you've got a risk of bleeding and a risk of the lung going down like a flat tire. So you have to have all of the precautions there and have a very careful assessment of the anaesthetic, etc. And you get a series of little bits of tissue that look like this, and this is stained under the microscope. And it's basically, after all the years we've been doing it, it's sort of the pathologist gets back to us and says there's too many blue cells, and it's quite amazing really that that's defined 30 years of lung transplantation. And they scale it between 0 is none, 4 is lots, and then there's a 2 or a 3, and most of them are sort of 2 is considered a problem, but it's as coarse as that, and I'm sure there are no pathologists in the audience, but we're very sceptical as the years pass. What we've always thought about is that it's very easy to actually to go down into the airways and just go and take a bite on that star there and just take a chunk of a little bit of tissue. You can see it. It's not going to bleed. It's not going to collapse anything, and yet that bit of tissue, there's no standard way of reporting that under the microscope looking for blue cells. They haven't come up with a way of scoring that. So it's currently known that you can do it, but it's not a standard way, and they have to do these extra more risky bronchoscopies. So along comes essentially the Gandalf the wizard here from Canada, who's a crusty old Canadian who's really the world expert on I think on the mechanisms of kidney transplant rejection. And he has pushed the idea of using gene signatures, molecular, very, very sort of fine tuning parts of the immune system, trying to understand those and how they have impact on kidney rejection. And it's to our luck that his son didn't want to do kidneys, did medicine, but did lungs, and is someone that Glenn and I have worked with now quite a lot. And he's been able to work with his father, and the two work together. And essentially, what they've found is that you can take tiny pieces of tissue, just two of them, two tiny bits, not lots of bits as you need to diagnose rejection with the little blue cells. And you can read the genetic signatures, and you can use the information he's generated in the past from kidneys and more recently hearts, and hundreds of lung patients from thousands of kidneys, and actually use the computer to tell you what are the signals that are there. And the first comment is that over the years, it's now apparent that the signatures, it makes obvious sense really, but it wasn't known, the signatures in the lung are the same signatures as in the heart and in the kidneys. Who knew? But there you go. It sounds obvious. And what they've been able to do is use the computers to basically fine tune what some of the clinical sort of typing is of the patients, and then the computer spits out a report. And it spits out a whole lot of things over here that basically on the left side, things to do with rejection, things to do with injury, things to do with just non-specific scar, and the like. And it produces scores of interpretation of how normal or abnormal they are, and sort of groups them together. And over time, he's modified these scores a little bit. And you end up with a little graph here. And basically, the axes don't matter. What we're talking of here is that colours here that that represent the most important components. And the grey is how normal it is. The red is how much acute rejection. The blue is sort of an example of how pure the tissue is, and late is just sort of scarring many years from transplant. It's turned out that there's the tissue looks different, 20 years on, 10 years on. It's just, even if the graft's working normally, there's still some change. And our particular patient, this is one patient's result, is sitting, that yellow triangle sitting there nicely in normal. And this gives you much more information than the little blue cell story, because it tells you how close you are to the edge. It gives you clues of the other parts of it, and gives you a score that you can look at over time. It adds to 1, and the score, 0.6 is normal. There's a little bit of a late change. There's no acute rejection, and maybe there's a little bit of the chronic rejection in there. So a remarkable amount of information that's been generated just off 2 tiny pieces of lung. So you might say, well, so what? Well, we've been involved in this right from the start, and Alfred patients, the Alfred team, have contributed. There's about 20 centres now involved in this, and we're the biggest contributor to this, and that's been generously done from the patient group, and generously supported by Lungitude, and Glenn has built up a huge big biobank of specimens that we can work with the Canadians. And it means that we're working with this particular team in Canada, but it's also links us to other very significant units around the world. So we've got, there's collaborations and discussions, and you get online with these people and talk about things. There's a number of high-impact transplant journal papers that have come out. There's 6 papers. And it started off describing it, and we've since found signatures with what happens with time, signatures with chronic rejection, signatures to do with trying to understand about antibodies, and the like. And so it's exploring, in a sense, almost starting again, trying to find what you find in tissue, and sort of saying that the old way of thinking about it with the little blue cells took us to the start, but it hasn't really taken us beyond. And you can use it as a safer rejection endpoint when you're trying to work out if you've got a medicine or a treatment and you're trying to say, well, did it really work? And the current bit of there's more or less blue cells hasn't really helped. But this, I think, will give us more ability to see changes, and we can test out new strategies. And so the second, what do we think here? Well, here's Glenn earlier this year on a big panel here talking about how this is how you can use this in hearts and lungs with Phil. And again, this is teaching the world as to ideas on this. And it leads to one of our current studies. So this is a study on inhaled tacrolimus. And essentially, we know that we need to immunosuppress the lung, but you give it to the whole body, as a tablet. It gets into the bloodstream and goes around to the kidneys and contributes to skin cancers and various other things. So it helps, but it's that risk benefit. And we know that inhalers have been very useful in treating other lung diseases in asthma and emphysema. And in lung transplant, people haven't really used inhalers much. So can we actually deliver the tacro just to the lungs through the airways and not have as much in the rest of the patient? So we're currently studying this to get going with this. We're currently looking at this in people whose kidneys aren't working so well, where we don't want as much tacro in the body, but we really wouldn't mind it in the lung. So instead of having a certain amount in the blood and a certain amount in the lung, we're hopefully switching this around. And we're using a simple puffer that's like some of the asthma puffers, where you just put the capsule in, crunch it, and you take a breath, 1 to 3 puffs a day with no tablet tacro. And what we're able to do is assess in these people. We can assess the kidney function that fairly easily with blood tests, but we can actually use these biopsies to actually test. And this is a patient here, and there he is in his yellow triangles, and you can see that 3 months after having his inhaled tacro, his scores are exactly the same. His little triangle sitting nicely in the safe zone. So it's giving us a real clue of that he's not out in the red, out in the off the fairway, out in the bunkers, out on the side there, and we're going the right direction. And I think this is the type of thing going forward that can be very helpful for us with studies, but even indeed in individual patients. So in conclusion, I think the collaboration helps us all. The collaboration between ourselves, our patients, the different research groups around us, Lungitude and the universities, and our overseas colleagues. What we're also trying to tell you here too is that using, I have no idea how that heart. And that using real tissue and real blood cells is really what makes the best difference. And you can only go a certain distance using the mouth or the mouse or the ferret model. And in this particular case, I think, can we use this biopsy technique? Can we use this clinically in lung transplant? And I'd really like to see that. The irony is that we currently take a specimen and send it to Canada, and they can give us a readout in approximately the same time as we get from our pathology department 3 floors below. So we are trying hard to try and improve these things, and we're enjoying doing it, and we'd like to thank everyone for being part of the team. So thank you.